First off, I want to thank everybody from Respiratory Associates, especially Keith, for inviting us to come on your broadcast today. My name is Matt Pavlichko. Some of you guys may know me as Matty P. I am the host of RT Sidebar, the #1 respiratory podcast in the world. And I'm super excited to tell you about high velocity therapy and what we can do to help you take care of patients. So we really think that that's important. Like I said, my name is Matt Pavlichko. I am from Vapotherm. I work as the Director of Professional Development and RT Education in medical affairs. So I do a lot of work with research development, but most of my time is actually spent with respiratory therapists, just like you, because I'm a respiratory therapist. So is my wife. We have almost 60 years of respiratory experience in my house. So it's kind of crazy. We love what we do. And we just think it's the greatest thing that we do, and we can provide to our society and in the world at large. So thank you for joining us once again. This is provided by Respiratory Associates. And once again, super excited to have you. A very quick disclaimer. I'm an employee of a medical device company, and things that come out of my mouth are all solely mine. This disclaimer is to protect Vapotherm and everybody around me from anything that comes out of my mouth. So really, I am my own speaker, but Vapotherm does not practice medicine. I do not practice medicine, and Vapotherm is for spontaneously breathing patients only. I have also fiduciary relationships with the AARC, the PSRC, which is the Pennsylvania Society for Respiratory Care, and the RT Sidebar podcast. We're going to play a game. I'm excited for the game after this that Keith's going to host. It's going to be awesome. But I want you to look at this picture. And when you look at these two pictures, there are 6 differences. And in the chat, I would like you to tell me when you get to 4. I'm going to give you 20 seconds. I'm going to bring up the chat. Please, I want this to be as interactive as possible. All right. There we go. So let me know when you get 4. All right, now we're getting somewhere. All right, we got some 4. Who has 5? Tell me when you get 5. This is awesome. Everybody's getting 4. Who's got 5? All right, Kristen, you got 5. That is awesome. Anybody have 6? This picture is a really tough one to find. 5 people can get, but 6 is pretty tough. All right. So I'm going to show you where these are at. There we go. So as you can see, there's 6 differences. All right. You guys want to try another one? All right, let's do it. So here's another one. Here's the Golden Gate Bridge. There are 6 differences here as well. All right. Let me know when you get 4. Put it in the chat so I can see how awake you are today. Who else has 4? Who else has 5? Who's got 5? Does anybody have 6? We got some 5s. All right, here we go. Here are the 6. I think that this one up at the top, the little sign that's green on this side and blue on this side, I think that one's the hardest one. So we do this for a specific reason, and this reason is when we talk about spotting the difference, there's sometimes that our therapies may look the same, but might be different. And sometimes they just look very different. So when I click on this picture and I want you to spot the difference, what is it that you see that is different? Put it in the chat. But I also want you to look at it from the patient perspective. What is different for them? It's very easy for us. One's a cannula, one's a mask. One is one that we apply when patients are hypercapnic. One is when we traditionally use for hypoxemia. Eyeglasses. That's marketing. So you can keep your glasses on. That's a big one. Communication, freedom. What about eating and drinking? More comfortable for the patient. I love that. What about the respiratory therapist? Which one's easier to apply? That one's a pretty easy answer, right? A lot of times we spend most of our time in the emergency room or at a rapid response. We use the non-invasive positive pressure ventilation. And what we do is we spend half of our day keeping the mask on, which is a huge problem for respiratory therapists, especially the lack of respiratory therapists we have in this country. So I think that if there was a way, and non-invasive positive pressure, I've been around a long time, it's saved millions of lives. Because if you go on a ventilator, the chance of you coming off are low, to be honest. The use of non-invasive positive pressure ventilation has kept patients off ventilators, and that's really what matters. But it's cumbersome for both the patient, the therapist, the nurse, and the family. Can you spot the difference with this one? Are all nasal cannulas the same? This has been a tough one because we believe no, because they're not the same. When you look at each one, you're like, okay, we're providing heat and humidity. It's doing everything that it needs to do, but are all high flow nasal cannulas the same? And the answer today, my job is to say and try to educate and entertain you that the answer is no, and that RTs may need some more tools in their toolboxes to take care of patients, because that's what we are. We are great craftsmen of caring for patients. So when we use the word high flow nasal cannula, and you go to Egan's, you go to any of, if there's any students out there, you guys know that a high flow nasal cannula has four specific things that make it a high flow nasal cannula. First one is heated, humidified medical gas conditioned to the nasal airway. Whenever I teach a nursing team, what's the difference between a high flow nasal cannula and a regular nasal cannula? Because they all freak out at the words high flow. I just say it's a hot nasal cannula. And when I say, oh, it's just a hot nasal cannula, that's easy. Okay. And that's really what it is. Heated, humidified nasal cannula. It is a nasal cannula interface. This one's important. It meets or exceeds the patient's inspiratory demand. Okay. This reduces the amount of air entrainment you can have. So you could deliver precise FiO2 at whatever flow that you want. So FiO2 and flow are independent of one another. The one thing that I always struggled with was I'm a NICU therapist. And when I used to give lectures about what is the difference between nasal CPAP and high flow, they are pretty close. But the one thing is a leak. Have we forgotten that a leak is a part of high flow nasal cannula? And I think sometimes we have. We look at high flow nasal cannula as a PEEP device, which it does provide some PEEP. Every 10 liters per minute is about 1 centimeter of water. So it does provide some PEEP, but is that truly the mechanism of action? And high flow nasal cannula became very popular during COVID. So those that didn't use high flow very often in adults, it was our lifesaver. It kept patients on ventilators without spewing germs all over the room and infecting respiratory therapists. So it was a great tool in our toolbox. We're going to talk about high velocity today. We're going to talk that nasal cannulas are different. So when we think about traditional high flow nasal cannula, we think type 1 respiratory failure. You have hypoxemic respiratory failure. SATs are low, give them oxygen, give them more until you can't, then you intubate them or move on. But I'm going to tell you that a small bore or high velocity system can also treat type 2 hypercapnic patients, type 3 perioperative patients, and then even type 4 increased work of breathing to shock and acidosis, so your metabolic abnormalities, that they can improve patients in all four categories. So here are our learning objectives. We're going to look at that. Does high velocity compare to non-invasive positive pressure ventilation support? We're going to understand the clinical evidence of its use in hypercapnia. We all know it works in hypoxemia. That's easy. But what about hypercapnia? And then we're also going to talk about the mechanism of action. What is the true difference between a small bore nasal cannula and a large bore? Okay, going back to the chat. Patient CO2 78728, what are you doing? Put it in the chat. What would you do at your facility? What is the doctor going to order? I'll give you a couple seconds. BiPAP. Oh, try heated high flow. Excellent. First, then BiPAP. Absolutely. That's great. Oxygen first line defense, yes. BiPAP, yes. So this is kind of normal. And why? 25 years of research that shows that BiPAP works and it keeps people off ventilators. The problem is this. So I'm going to give you a story, okay? Your patient comes into the emergency room with a CO2 of 78. They have increased work of breathing and a pH of 7.28. The doctor calls you to bring in a non-invasive positive pressure ventilator, whatever one it is. And it's a little old lady. I'm from Pennsylvania. It's right after Easter. We eat too much. We eat too much ham. Our salt goes up. We're all in CHF, right? And what do? We put them on the non-invasive positive pressure ventilation. And I'm old school, remember that. So as soon as you hit the door to go back, pick up your coffee that you've warmed up 5 times, what happens? Your beeper goes off. You go back to that room, and what do? You tighten the mask, ma'am. You need to keep this on. We just need to do this for a couple hours until you pee, and then everything's going to be okay. Your breathing will feel much better. And then as soon as you get back to the door, your beeper goes off again, and you walk on back to the room. They took it off again. You plead with them to keep it on. You do one of these. You tie it as tight as possible because it's just what we do. Please leave this on. If your beeper goes off 3 times, your patient is going to get prepared for intubation. Those patients that get intubated have a risk of death. A friend of mine, I believe it might have been even Gary Kaufman, says you can't get a VAP if you're not on a ventilator. So keeping patients off ventilators matter, but BiPAP is cumbersome. But it's what we have. Do we have any alternatives? Well, we traditionally believe that this is the alternative. It is BiPAP for hypercapnic patients. And then if they don't work, it's going to move to mechanical ventilation. So is there clinical evidence supporting the use of a small bore? So when we think small bore, high velocity, large bore, high flow, keep them the same, keep them synonymous. You'll understand where we're at. So we're going to talk about small bore, high velocity therapy for hypercapnic patients. And there are 3 major randomized controlled trials that look at, does high velocity nasal cannula for hypercapnic patients work as well as BiPAP? Not superior, not inferior. We call it non-inferior, which equals the same. Do they do the same job? And as a consumer, because I've only been at Vapoflume for a little while, as a consumer, if somebody told me, which they did, that a nasal cannula could blow off CO2, I laughed in their face. My poor rep, Matt Slater, I laughed in his face, and now he reminds me of that every day. But is there evidence that shows that high velocity nasal oxygen therapy, small bore cannulas, can reduce CO2? So the first one was in 2018, done by Pratik and Pratik Doshi and colleagues looked at high velocity therapy compared to NiPPV failure to intubate. Okay, so patients that presented to the emergency room with increased shortness of breath that were hypercapnic, the 204 patients equally divided on the high velocity group or non-invasive positive pressure ventilation, and intubation or crossover to other therapy was the primary endpoint. And there was no statistical significance that either one was better than the other. So your intubation, non-invasive positive pressure ventilation happened a little bit more than high velocity, and arm failure rate happened a little bit more with high velocity compared to non-invasive positive pressure ventilation. I will tell you, as a consumer of respiratory products, because I've been a respiratory director for a long time, this is the next slide that changed my life. Doshi did a subgroup analysis of just COPD patients with hypercapnia. There are 65 of them, and they compared PCO2 and pH levels of both modalities. And what they found is that the decline in CO2 in the non-invasive positive pressure ventilation group and the decline in CO2 in the high velocity therapy group were the same. pH trended the same as well. And why this bothered me so much is I thought about, hey, how many BiPAP patients do you think we've all taken care of? How much time do you think you have spent in your career adjusting non-invasive positive pressure ventilation masks? Think about how much time that has been spent in your life doing that. It seems like a lot of time that could potentially have mask intolerance. That could potentially take it off when a hot nasal cannula, that small bore, could have done the same thing. So it bothered me the first time I saw this because I thought about all that time. But it's one study. I'm never going to change practice over one study. So Gustav Plotnikow, who does a lot of articles in Respiratory Care Journal, in 2021 did a study looking at COPD patients in Argentina. There were 7 hospitals that looked at COPD patients with acute on chronic hypercapnic failure. Multi-center study. And what they looked at was, did these 3 things improve? Did respiratory rate improve? Yes. Patients on high velocity therapy had an improved respiratory rate. Patients on high velocity therapy had an improved accessory muscle use. And then lastly, the PaCO2 lowered about 10% within 1 hour. The same times that the same slope of the Doshi study, about 10% in 1 hour. And you're like, holy cow, that's pretty crazy. So we have it again. So, okay, I might try it. I believe somebody in the chat said, hey, we're going to try heated high flow before BiPAP. Yeah, because if you have a low CO2, you get their breathing under control, they'll probably equilibrate. Okay, so yeah, if your CO2's 57, I would do it too. But then the question came up is, how high could you go? And this is a comfort thing. If you're ever going to try small bore nasal cannula, high velocity system, and CO2 is 110, and you're like, hey, Matt, I don't feel comfortable with 110 CO2. I don't either. It's all about how comfortable you are. And that's really what they wanted to see. So there was a study called the HyperX study that came out in 2024. Once again, 7 hospitals, randomized multi-center trial. The primary outcome was reduction in dyspnea after 4 hours. Okay, there's a reason for that. This is an emergency room study. A lot of times in emergency rooms, they don't care why you're short of breath. They just want to make it go away, to be honest. But what they did is they looked at patients with a CO2 greater than 60 and an acidotic pH, 7.0 to 7.35. If you look down here at the bottom corner, you'll see CO2s in both arms. There were 36 in the high velocity arm and 32 in the other arm. The CO2 was about the same, 77. pH was 7.27, and the dyspnea score is about 5.5. So you could argue these are sick patients. They also looked at physiologic parameters like SpO2 and vital signs. They looked at VBGs and then dyspnea, but also the patient's and physician's perceptions of clinical stability. Did it do the job? And when they looked at this, as you can see at the bottom, very sick patients. But then we're going to go over to this box and whisker plot. How did they actually do? So when you look at the box and whisker plot, I always look at these the same, okay? The dotted line's your mean, okay? So at baseline, they're about the same. At 30 minutes, they're about the same. At 60 minutes, about the same. 240 minutes, 4 hours, about the same, okay? And as you can see, the boxes are a little bit different. There's other variables, but there's a couple things I want you to be able to see. First off, there was a couple patients with CO2s in the hundreds, up to 120. These are sick patients. But what you see is a gradual decline. What I also noticed as an RT, because I know that this has happened to all of you guys at one point down in the emergency room, did you ever have a patient that you put on BiPAP, you come back to the room and they're out of it? And you're like, oh my God, their CO2 is probably 200. And what ends up happening is actually their CO2 is 25 because you blew them off too much. And now you're like, uh-oh, that can happen. And it can happen on the non-invasive positive pressure ventilation group because it has a rate and it has a mandatory tidal volume. In the high velocity group, all you have to do is open your mouth. You're self-regulated. If your CO2 starts to become below normal, you'll just breathe slower. So primary outcome was dyspnea. Okay, so we started around 5.5, we ended around 3.2 in both groups. High velocity therapy was non-inferior in relieving dyspnea at each time point, excluding baseline. Okay, it's got a p-value of 0.05 because it was looking for non-inferiority. They wanted to show that it was the same. So perceived dyspnea was better. And then also they looked at the stuff that we care about. pH, CO2. Mean pH rose at almost a similar slope from 727 to 731. And then once again, the CO2 from 77 to 67-ish, same slope over time. It took me off guard. I'm going to be very honest. I didn't think it was going to be this good. I can say that as a consumer, during COVID, I had patients with undifferentiated respiratory distress. And whether it's oxygenation or CO2, I just threw everybody on. And my outcomes got better. So for me, seeing this data makes me feel that yes, it can manage patients with acute hypercapnia. It cannot manage patients that need tidal volume. And that's an important piece. Tidal volume is still required in mechanical ventilation and non-invasive positive pressure ventilation. This is my favorite graph because you don't need a graph to say that it was more comfortable. But can you imagine that a cannula is more comfortable than a mask? High velocity failure rate was only 11%, which is pretty typical. 11 to 20-ish% is pretty typical for all non-invasive modalities. So how is this possible? Well, it's possible because we have to go back to EGANS. Now, we were laughing. I was just at the New York Society for Respiratory Care, and we were talking about EGANS. And today's EGANS is like this thick. It's gigantic. The EGANS that I had was half the size. So I always say, oh, well, your students have to learn a lot more, which they do. There's a lot more science than there was back in my day. But this is Anatomy and Physiology 101. Okay. When we think about CO2, we think minute ventilation because I can increase the respiratory rate or decrease the tidal volume. A lot of times in the ARDSNet days, we do not mess with tidal volumes really anymore. We would mess with respiratory rates. And that is how we manage CO2. But it's not the only way you manage CO2. If you go back to EGANS, there's also the alveolar ventilation equation that has inspired volume, your tidal volume, but it also includes dead space. And dead space is something that we don't think about all that much because most of our patients, when we're considering dead space, they're intubated. We have ventilators, we have non-invasive positive pressure ventilators that overcome some dead space. That's their job. But if you think about it, dead space, in its simple terms, is like when you're laying next to your spouse at night and they're blowing their CO2 in your face. It doesn't feel good. It's like, ugh, it's kind of gross. But that's what dead space is. And dead space is what we forget. The column of gas above your carina through your nasal passages is all CO2 rich on the end of exhalation. So when you inhale the next time, the beginning of your inhalation is dead space and it's used gas. So if you could get fresh gas into space, like your non-rebreather bag, if you could have fresh gas in this space, you have a reservoir of fresh gas that is not CO2 rich. Could you reduce CO2? And the answer is yes. If you need inspired volume, you're going to need a non-invasive positive pressure ventilator. If you have ALS, any type of musculoskeletal issue, you're going to need it because you need tidal volume. But those that don't need tidal volume and just want to reduce dead space, high velocity therapy can do that. So are all nasal cannulas the same? Remember, I'm a NICU therapist. One looks a lot like bubble CPAP compared to the other. That's the way that I've always looked at it. And that helps me really understand the difference between the two. So why does this work? Now, I will tell you, And don't put this on my evaluation, please. This sounds so gimmicky and it's like so much marketing material. It's ridiculous. And I felt that way too. But physics tells you that flow and velocity are two different things. Flow is volumetric. Velocity is speed based on distance. So a lot of you guys, if you're down in the South, have lots of pollen all over your cars, or you go to wash your car and there's something on your car that you want to get off of it. And you don't have one of those fancy squirters. So you really want to move the water faster. What do? You do you do that. If you have a dirty bucket where you have dirt on the sides and you want to get it out and the regular flow is not working, you put your finger over the hose. Why that's important is I didn't change the flow at the spigot. So the flow, whether it's 40, 60, whatever it is different at the spigot than when it goes in your nose. And that's an important concept. That concept of speed matters because our patients don't breathe 12 and 16 times a minute, even though that's sometimes what we chart. So they breathe faster than that. This is respiratory therapy superpower. We don't count respiratory rates as much as we should because we can look at a patient and know what to get. We could walk into a room, look at a monitor, look at a patient, we're out, we're getting our stuff. Because we know. We don't have to go, let's count for, 30 seconds and see what our respiratory rate is. We don't do that. But our other colleagues do. Our patients breathe more than 12, 16, or 20. And if you're breathing fast, what happens to your expiratory time? It shrinks. That shrinkage of expiratory time means that if you're going to flush dead space, you need to move quicker. There's two ways to do it. Increase flow or decrease the diameter of the tube, which increases velocity. And if we go back to the previous slide, as you can see, the decreasing of the tube actually increases the speed more efficiently. So efficiently that at high flows with a small bore nasal cannula, you can clear the upper airway in 0.3 seconds. I always say that if your expiratory time is less than 0.3 seconds, you probably need a mechanical ventilator. You're in big trouble, or you're a neonate. And this is really important. If you could get this column of gas, that CO2 rich gas, and have it good fresh gas, your CO2 will come down. Same as non-invasive, just different mechanism. This is from my friend Scott Leonard. He's an engineer and he did some computational fluid dynamics is what this is. So what they're looking at is they're looking at a cross-sectional view, so straight on, and you can see that the red is CO2, okay? On the left-hand side, you see an actual smaller bore cannula than you do on the right-hand side. And this has to do with speed. So all of this on the left that's blue in the upper airway is all fresh gas. Fresh gas that the other patient with a larger bore cannula does not have. So are all nasal cannulas the same when it comes to hypercapnia? They're not. And there are studies, all the studies that I've read have shown that. Any questions, comments? I'll give you about 20 seconds if you want to jot something down. We will definitely go into it, but think about it. Like, this is a concept that's weird, it's something that's untraditional, but I think it's an important concept to have because you need to have lots of tools in your toolbox. So if you have any questions, throw it up in the chat. We'll definitely answer them. We'll try to get them in themes and we'll answer them at the end of the show. Does high flow nasal cannula or high velocity oxygen therapy, either or, do they work great perioperatively? Sure. Do you ever use a high flow before you intubate? Gives you a lot of extra time. Do you use it in the recovery room? Sure. How about those that are facilitating extubation? There's a couple really good studies out there that say, okay, Instead of putting patients on non-invasive positive pressure ventilation post-surgery, could you put them on high flow and get the same outcomes? And yeah, absolutely. High velocity as well. Can it prevent post-op reintubation? Of course it can, because it supports work of breathing. But small bore has a better chance to support work of breathing than a large bore, because large bore just works on oxygenation. And I put this one in here because I think it's important. We're not always clinicians. Sometimes we're family members. This is my dad. He hates that I took this picture right after open heart surgery. But imagine you just had open heart surgery. You just had your sternum split in half. They fixed you. They stitched you back together. We know as respiratory therapists, getting them off the ventilator is the first biggest hurdle. When they come back to ICU, that is our job as RTs, get them off the ventilator, because the longer they're on the ventilator, the higher the risk of complications. So my dad was on the ventilator a little too long for my liking. And my wife and I are both therapists. And it was actually at the hospital I used to be the director at. And they were moving a little slower than I wanted them to. And they're like, his oxygenation's high. I go, yep, but he could swallow and follow commands. Let's go for it. Come on, let's do what we need to do. And they're like, well, we normally extubate to BiPAP after, if we're having troubles. I said, over my dead body. Can you imagine after you had your sternum cut in half to take out that tube to have that mass smashed to your face? I can't imagine it. I'd rather be intubated, to be honest. You're on lots of meds. You need to be able to move. You need to be able to get off the ventilator and move. You need to be able to be a human again. And I believed, and I fought for my dad, that he did not need pressure, but he just needed velocity to help support his work of breathing. He came out great. He's doing great. He went through his cardiac rehab very fast. But that was an emotional time that I saw my dad, who was on high velocity therapy for 4 days, improve. This last one's weird, okay? Because when we think about work of breathing, we think about the lungs. That's what we are. We're lung whisperers. But not all work of breathing is lung related. And we know this. We think about it all the time as RTs. Obviously, the lungs are the tip of the iceberg. The things we know, our bread and butter, the things we see every day. Pneumonia, pneumothorax, COPD, chronic bronchitis, ARDS, PEs, lung. Is it obstructive, restrictive, or both? That's how I've always looked at it. And then I have the tools in my toolbox to fix that. But these aren't the only reasons to be short of breath. These aren't the only reasons to have increased work of breathing. The heart, shock, CHF, tamponade, arrhythmia, myocardial infarctions. Do all of these patients have increased work of breathing? They do. How about anemia? How about methemoglobinemia? I still can't believe this, but if you guys watch The Pit, they had a patient with methemoglobinemia. I thought it was the coolest thing ever. I've never actually seen methemoglobinemia outside the neonates. I thought it was pretty cool. But we also know that those increase work of breathing. And metabolic acidosis. Metabolic acidosis is interesting, right? My very first worst metabolic acidosis I ever had was a 9-year-old child in diabetic ketoacidosis. Their CO2 is 8. 8. They're like, oh, well, they're keeping up. They're doing just fine. Their CO2 is 8, but they're chugging along. Look at your patient, right? They are working really hard to breathe. Can we support them as RTs, the lung whispers? Can we support them with our fancy tools? Those patients that are not traditionally managed with sometimes not even RT. I want everybody to take out their phone and take a snapshot of this picture, because I think that this is the most important picture you could ever show any respiratory student ever, because every single one of us have been in this situation. And I could tell you mine. I had a 12-year-old girl admitted to my pediatric ward at my hospital that I worked at when I was a baby RT. We go in and this girl is pulling hard. Asthma, bad. We already were on steroids, continuous albuterol. We already gave TURB. We were thinking about what do we do if you have to intubate? And if you work with kids, intubating an asthmatic is the worst because they fight the ventilator. and there's not much you can do. They're going to air trap. They're going to be a mess. You're going to put them in ARDS, and you don't want to. You're going to do your very best, but they're that sick. It's very hard. And my doc friend, who was my mentor, goes, "Hey, Matt, I hate doing this, but I want to get a blood gas. I just want to see where the CO2 is at." So I quick got it. Remember, I'm a baby RT. I quick got the blood gas, and it came back, and it was 740/40. And I'm like, "Look, it's good." And he kind of yelled at me in front of everybody. He goes, "Matt, you're a respiratory therapist. Does this patient look good?" I said, "No." "Then we're going the wrong way." Because as we know, as respiratory therapists, when a patient's in distress, their CO2 is going to come down. Then when it starts to come back up, they're on the wrong swing. A lot of times we think numbers, but we know as respiratory therapists, patients matter. So look at your patient. So you'll see a decline in your CO2 till it goes up. You'll see an increase in respiratory rate till apnea happens. You'll see SpO2 being just fine until it's not. I always say if you have a low sat on an asthmatic, you're in big trouble. And we know this, but I also don't believe that everybody else knows this. So if you have a patient, no matter what they are, increased work of breathing, this is the cycle they're going to go through, every single one of them. The problem is, and this is my concern, and this is where I advocate for respiratory therapists more than anybody else. I don't care why you're short of breath, but can you give us a call? Because this is where you have a normal ABG. This is where we're not getting called. This is where we're getting called. They call us to be, we always say that we are superheroes because we are superheroes. We bring people back from the dead, but I'd rather prevent that code or that rapid response rather than get called too late. So are we getting called in triage for every DKA patient with increased work of breathing? I know we're not. Are we getting called for those CHF patients that just don't look great, but they're on some oxygen, but they're hanging in there? Are we getting called for those patients? We're not. So this is where I really push all of you guys to consider, are you getting called for all of these patients? Because this matters. Because if we get called during a normal ABG, we can prevent the abnormal ABG. To me, it will always be airway breathing circulation. I know it's circulation, airway breathing, but breathing prevents the need to fix circulation. And there's studies to prove it. Early intervention matters. Oh, we know this. If you come in with dyspnea score of 0, your chance of leaving the hospital is 0.8%, which I believe is astronomical. But if you come into the hospital with a dyspnea score greater than or equal to 4, it's 4 times higher chance of not leaving the hospital. So fixing work of breathing when it happens matters. What about work of breathing on cardiac output? Okay, so you have a cardiogenic shock patient that's chugging away because they have a huge metabolic acidosis, and they're working hard to breathe. Well, that work of breathing is impacting their cardiac output, which is suffering at the time. So managing those patients that have poor cardiac output and their work of breathing will actually help them out as well. So if your patient is short of breath, call an RT. We don't care why they're short of breath. We'll fix their shortness of breath. And that's where I believe high velocity therapy and all the tools in your toolbox can help a respiratory therapist. So when I look at this, I think that high velocity therapy, small bore nasocanial technology, heated humidified, does everything you need it to do, easy peasy, lemon squeezy type of work. It can manage all 4. Obviously, it can manage hypoxemia. That's easy. We showed some studies about hypercapnic. Type 3 in the perioperative space just makes sense. And then lastly, patients that are short of breath for non-hypoxic or hypercapnic needs, your increased work of breathing. They're short of breath too. Just because it's not lungs doesn't mean a respiratory therapist can't step in and help you out. So some of the takeaways I have for you: high velocity therapy is a reasonable alternative for patients with COPD and hypercapnic respiratory distress. We saw that. High velocity therapy may lead to reduced rates of intubation for patients unable to tolerate NiPPV. We have customers that are using this in every aspect, and we have customers that aren't comfortable yet. This is a relatively new concept. Can we continue to make this better? And I think that's kind of where we're at. So your patient, back to the chat, guys. Your patient in the ED comes in with a CO2 of 78 and a pH of 728. What would you consider now? Put it in the chat for me, guys. Gals, high flow. Yeah, high flow. Yeah, why not try it? There's actually a trick to it too. Ready to hear the trick? There are studies that show that you should see an improvement in 1 hour, right? We showed that 1 hour you should have a 10% reduction. If your patient gets worse or you don't see that 10% reduction, it's time to move on. The golden hour, that's what it is. There is a white paper on the Vapotherm website if you'd like to take a look at it. I'm super proud of it because I wrote it, but there is an option to do that. Try it. Anybody will try something for an hour. And literally, if they don't get better, get them out of here. If you're going to change the viewpoint of anybody, it takes education and time. Education, 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 education. But it's also about finding the person you can educate. We all have doctors. We all have a hospitalist that we know are going to pick BiPAP because it's the easy button. It's the button they have. Or it's already auto-checked in Epic, for God's sakes. It's like steering a cruise ship. This is how I do it. Find a doctor that likes you, that trusts you, and you trust them, and convince them first. Sometimes we as RTs can't convince a physician, especially a grumpy old one. But can a physician convince a physician? That's a better chance. So I like to use my peeps around me to help change people's minds about different things. And it could be about anything. It could be about Flolan and nitric. It could be about anything that we've done in a long time. It could be about driving pressure. Everybody was so argent that, and nobody worried about driving pressure forever. Like, what are you doing? We have a driving pressure of 30. I'm glad that, you're at 6 mLs per kilo, but come on. It takes time. It takes persistence, and it takes finding the right people and telling them the right thing, the thing that they need to hear, the thing that's going to help them take better care of their patients. You need them to slow down and think. So I wish I had a magic bullet for that one, but some of them are. I work on the younger ones. I work on the younger physicians, APPs, nurses that haven't been kind of stuck in their ways. It's hard to teach an old dog new tricks. So here's my advertisement. Obviously, I told you at the very beginning, I am the host of the RT Sidebar respiratory podcast, #1 respiratory podcast in the world. We're here with Mindy Conklin, the very first advanced practice respiratory therapist, and JJ Valdez, who's JJ the RT, huge Instagram following. The three of us run RT Sidebar. We have 2 episodes a month. And what we do is we talk to other respiratory therapists about how great it is about being a respiratory therapist, how to empower, how to champion, and how to influence in a way that might be different than our friends at Respiratory Therapy Break Room. That's a little negative. We try to be positive, and we try to get our community of respiratory therapists feeling good about themselves again. So if you ever want to listen, check out RT Sidebar on any of your podcast outlets and YouTube, Instagram as well. This is the positivity that we have. This is us all laughing during RT Sidebar, having a great time. This is my favorite one over here with Jonathan and I. Jonathan's my former co-host. He is telling me a story about how he got report from somebody on a patient that was dead. So we all have crazy stories. And you know what? Those crazy stories that we have as RTs sometimes need to be shared. Those are fun stories. Some of them are crazy. You're like, did that really happen? Oh my God. Like I just told a story about pulling a tooth out of a patient's lungs. That was interesting. But we all have fun stories, and that's what it's all about. So if you ever want to join us, you want to give some shout outs, send us a message anytime. The greatest thing about this is I once again want to thank Tori and Keith for allowing me to host a CEU with you guys. Super excited and pleased to be a part of Respiratory Associates. So I'm going to hand it back to Keith to make sure that we go over the CEU activities and how you get those. But I'm going to stay online for a little bit and answer any questions that you guys put up in the chat. So thank you once again. Appreciate it.